Welcome to the first presentation on Krok 2 2023 booklet. Krok 2 2023 booklet. All right, the first presentation. So let's begin right away. So for intensive infusion therapy, a patient with acute respiratory failure underwent subclavian vein catheterization using the Serdinger technique. After administration of 600 ml of the infusion solution, the condition sharply deteriorated. Tachypnea increased from 26 to 40, tidal volumes decreased from 400 to 250, percussion, and so on and so forth. What complication has developed in this patient? What complication has developed in this patient? So first thing first, the patient has acute respiratory failure. What does it mean? What it means is that there is inadequate gas exchange by the respiratory system. And what that means is that the arterial oxygen, carbon dioxide, or both cannot be kept at normal levels. So that's what is actually happening in this patient. All right. So the patient is struggling to breathe. However, the patient needs to be given some IV medications or some IV fluid, for which they pass a catheter called the subclavian vein catheterization, and then they gave 600 ml of that infusion. Now, later, the condition became bad or became worse. It became worse. So what happened? This is just like somebody who is under the sea or who is in the water, who is struggling to breathe. All right. What it means is that the chest is flooded with fluid. The chest is flooded with fluid. And that phenomenon is called pulmonary edema. That phenomenon is called pulmonary edema. So over here, your answer is C. Your answer is C. So the fluid there must be taken out to help the patient. So you give Lasix or furosemide to sharply take away the fluid from the lungs to make it easy for the person to breathe. A 46-year-old man came to a doctor with complaints of rash on his hands that appeared a week ago, accompanied by severe itching. So there's rash, there's itching. All of these a week ago. Look, patient has a history of bronchial asthma and seasonal allergies. What does it tell you? For me, it is telling me that whatever the person is having could be an allergy. It could be an allergy. Now, physical examination detects that there is a dry skin or the hands, and there are multiple erythematous papules and vesicles with serous content, as well as areas of lichenification and excoriation on the back of both hands. What is the most likely diagnosis in this case? So like I said, definitely you are looking at a possible what? Allergic reaction. And that is called what? Atopic dermatitis. Atopic dermatitis or atopic dermatitis. Another name for atopic dermatitis simply means eczema. It simply means eczema. And eczema is simply a condition that makes the skin red and itchy. All right. Common in children, but it can occur at any age. It can occur at any age. Usually it is long lasting. That means it's normally of chronic in nature and tends to flare periodically. It tends to flare periodically. And how to know this is the history. The history. For the fact that there is a bronchial asthma in this patient history, some allergies and things like that. Definitely you are thinking in that direction as well. So over here, the right answer is what? Atopic dermatitis or eczema. So your answer here is A. A 30-year-old woman came to a doctor with complaints of menstruations. Complaints of menstruations that have been missing for 2 years after her second child. So she's not experienced menstruation for 2 years now. So you can imagine, is she pregnant? if she's pregnant, then the abdomen should show, right? But maybe not. So let's continue to read. So the childbirth was accompanied by a massive bleeding. So you see, so there was what? Postpartum hemorrhage. A postpartum hemorrhage. Of course, they don't quantify the bleeding, but they say massive. Take it as it is. Massive. Massive. So, and you know, one of the things that can happen in postpartum hemorrhages, that the pituitary gland could be affected, all right? And if the pituitary gland is affected, usually it will cause a feedback to, the hormone levels will be reduced. And when hormone levels are reduced, what it means is that the normal way of a woman menstruating will all be affected, to all be affected. Now, they said after the giving birth, the woman started noticing hair loss. So there's hair loss, there's weight loss. Woman's body type is asthenic. Her genitalia are hypoplastic. Cervix cylindrical. Body is of the uterus is small and painless. Uterine appendage cannot be detected. Definitely, you are looking at what we call Sheehan syndrome. Sheehan syndrome, which simply means pituitary amenorrhea. Pituitary amenorrhea, and that is caused by the massive PPH, or the postpartum hemorrhage that the woman experienced during childbirth. So we don't take PPH we don't take it lightly at all. It's a very serious condition. We always try to prevent as much as we can. All right. A 34-year-old man fell ill 3 days ago after an exposure to cold. When we say exposure to cold, it could be the normal cold. It could also be a flu. Flu is also a cold. All right. So they've been an exposure to cold or flu or whatever it is. He complains of fever 39.2. There is general weakness, which is marked, sweating, and cough. The cough was initially dry, but within the last 24 hours, it's now rusty sputum. It is now rusty sputum. What it means that there is something in the lungs that is trying to come out. And what could it be? Of course, it could be fluid. It could be fluid. It could be fluid. Now, if they give you a characteristic of a pinkish sputum, down without a doubt, you are thinking of what? Edema. But with a rusty sputum, you are thinking of any possible sign of what? Consolidation. That is what comes to the mind. Now, objectively, examination detects herpes on the lips. Percussion revealed a down sound on the lower lobes. Auscultation detects bronchial breathing and tachycardia. No changes were detected in the organs of the abdominal cavity. So abdomen-wise, everything is intact. So what are you looking at? What are you looking at? Definitely, like I said, these are signs of what? Consolidation, isn't it? And the thing that comes to your mind is definitely pneumonia. Definitely pneumonia. But the question is, what type of pneumonia are they talking about? What type of pneumonia are they referring to? Now, pneumonia can be classified in so many ways. One of the ways is where you got the pneumonia, which could be, is it community acquired or hospital acquired or health system acquired? When we mean hospital acquired, it means that you got it in the hospital. And when we say community acquired, you got it few minutes or hours before going into the hospital. These are some of the dynamics you need to know when it comes to hospital acquired and community acquired. Another way of classifying pneumonia is the bacteria that, the causative organism, which is what? Could either be bacteria, could either be a fungi, or it could be what? Be viruses. Now, when we narrow it into community acquired pneumonia, all right, one of the causes, the most abundant or the most common causes of community acquired pneumonia is caused by bacteria. Caused by bacteria. To be specific, we are dealing with what's called Streptococcus pneumonia. Streptococcus pneumonia. That is one of the major causes or the common causes of community acquired pneumonia. Now, This can occur on its own, or one can get it after the person has been exposed to cold or had a flu. So I think you can connect, right? So we're looking at what? Pneumococcal pneumonia. We are looking at what? Pneumococcal pneumonia, which is also a type of community-acquired pneumonia. Very, very important too. Also a type of community-acquired pneumonia. Again, we can also describe pneumonia based on the affected area. For example, is it affecting a lobe? Right? And that we call it what? Lobar or Krupus pneumonia. Lobar or Krupus pneumonia. And normally, when you get Streptococcus pneumonia, normally you are getting a lobar type of pneumonia or a Krupus pneumonia. So this question is very dicey, all right? It can go either way. So it can either be community-acquired pneumonia, which is focal. They say focal. And I can agree with them to some point because they say that the percussion sounds are just in the lower pulmonary lobes. Okay, so it can be focal. But again, in focal, they will give you some dimensions of what to actually look out for. All right, and that is over here. I am more than convinced that this one we are dealing with Krupus pneumonia instead of focal pneumonia. We are dealing with what? Krupus pneumonia. Krupus pneumonia. So your answer is E. But of course, if you think otherwise, just let me know in the comment section and we'll talk about it in details again. A 65-year-old patient was prescribed pharmacotherapy. That is what? Ramipril, atorvastatin, amlodipine, acetylsalicylic acid, bisoprolol. So this is like ACE inhibitor. This is that is for, how do you call it? Atorvastatin is for, these are the statins. They break down cholesterol, very good. Amlodipine is, of course, for hypertension. Acetylsalicylic acid also for hypertension can also be used for disaggregation, okay, to prevent platelet aggregation, right? Bisoprolol also for pressures, all right, good. Or that's the beta blockers, right? I think so. So all of these they are using for essential hypertension with a concomitant ischemic heart disease. 2 weeks later, he consulted a doctor about a dry cough. Now, one of these medications will give you a dry cough. And normally, they belong to the group called what? ACE inhibitors. So all the they are all what? ACE inhibitors. Now, examination detects no signs of acute respiratory viral infection or damage to the bronchopulmonary apparatus. A side effect of, you see, ramipril was suspected or is suspected. What drug can replace it? What drug can replace it? So now you ask yourself, what is the mechanism of action of this ramipril? Like I said, it's an ACE inhibitor. So what it does is that it blocks the enzyme called what? So ACE means angiotensin converting enzyme. So it blocks the action of what? Angiotensin converting what? Enzyme. Now, normally we have enzyme and then we have what? Receptors, right? So enzymes, receptors must receive it and then it will couple the action, right? So if you are not blocking the enzyme, then you can also block what? The receptors, right? So we have what to call angiotensin receptor blockers. Angiotensin receptor blockers. That's the ARBs. ARBs, angiotensin receptor blockers. And from the option over here, the answer for angiotensin receptor blockers are the tantans. So we call it what? The valsartan, losartan. These are all drugs that belong to the same what? Group. Losartan, valsartan. So over here, our option, the option that we consider here will be what? The valsartan. because it also works in a similar way like the ACE inhibitors. At the long run, the ACE or angiotensin converting enzymes will not be able to elicit their functions, right? To be able to elicit their functions, causing vasoconstrictions and the rest. So we're trying to prevent that from happening. So over here, your answer is what is E. Now, 2 weeks after a case of tonsillitis, I always say if you get a case of this thing, you don't even need to read. Have your differentials in your head. Again, you can have a problem with the heart. One of the things that can cause is what? Mitral valve stenosis, infective endocarditis, myocarditis. These are some of the things you can have when you have tonsillitis. Another thing is the kidney. So we call it acute glomerulonephritis. It's a possible cause of tonsillitis, right? Good. I mean, when you get tonsillitis, you can get it. You can get these conditions. So always it should be at the back of your mind. So it will help you to know which area they are talking about. So 2 weeks after that, a 29-year-old patient noticed a facial edema. There is weakness and there is decreased work capacity. Gradually, he developed shortness of breath, leg edema, and a lumbar edema. His skin is pale, heart sounds are weakened. He has hydrothorax and nasaka, blood pressure of 150/100. Clinically, urine analysis shows what? Specific gravity of this protein of 9, erythrocyte 40-50, hyaline cast 4-6. What is the provisional diagnosis in this case? Obviously, you know that we are dealing with a kidney problem. We are obviously dealing with what? With a kidney problem. And this is called what? Post-streptococcal glomerulonephritis. Post-strep glomerulonephritis. And in this condition, we can have both nephrotic and nephritic syndromes presenting. Both nephrotic and nephritic. If you've watched our previous videos, you will know what I mean by nephrotic and nephritic. All right. All the triad, you should be able to distinguish between all of them. But in all, they are all linked to what we call what? Glomerulonephritis. That's why over here, your answer will be what? Will be A. Acute post-streptococcal glomerulonephritis. That should have been the right terminologies or the right diagnosis. But in place of that, acute glomerulonephritis is absolutely correct. So your answer here is A. During Coke production, those of you like drinking Coke, all right, the concentration of dust in the air of the working area has been for many years exceeding the maximum permissible concentrations of 4 to 8 times. So again, those who do with Coke production, they are having some substances exceeding the maximum permissible concentration. What is telling you that they are looking for what? For occupational hazard or occupational disease. Occupational disease called what? Pneumoconiosis. Pneumoconiosis. So the question is that what substance or what chemical is it involved or do they normally use when it comes to Coke production? That is your catch. If you're able to get that, then trust me, you are good to go. And normally, they use what we call coal, C-O-A-L, coal. All right, they use called coal. That's what they use. Of course, there are other substances, other chemicals that they use, but one of the most important, because they can also use hydrogen, methane, ethane, carbon monoxide, carbon dioxide, etc. But in this question, the hazard they are looking for is coal. And that is over here. You are looking at what? At anthracosis. Anthracosis. So your answer here is A. Anthracosis. All right. A 14-year-old girl is being examined by a pediatrician. He has tail structure. He has is it a tail stature? Okay. Asthenic body type, striae on the skin of the abdomen, blue sclera. She was diagnosed with scoliosis, scoliotic posture, and chest deformity. She has hypermobile joints. Her fingers and arms are long. Cardiac ultrasound visualizes a mitral valve prolapse. What is the most likely cause of her tall stature? This is tall. Yes, a tall, not a tail. A tall stature. All right, what are you looking at for? Over here, you can easily move some things out and be free, like Klinefelter syndrome. You know, Klinefelter syndrome is happening in a boy, not a girl. It's coming in a boy. So you have the XXY. So easily you can rule out Klinefelter syndrome and be free. However, over here, what we are looking at here is what we call what? The Marfan syndrome. Marfan syndrome. One of the most popular people who died years back had Marfan syndrome. I've got the name of the person. I don't want to guess wrongly, all right? But he had what? Marfan syndrome. They are very tall. Very tall. And about 60% of them have scoliosis. They have what? Scoliosis. About 60% of them end up having scoliosis. And you know that Marfan syndrome has to do with a problem with the connective tissue. A problem with the connective tissue. It can affect the heart, the eyes, the blood vessel, and the bones. And they are normally tall and thin with long arms, legs, fingers, and toes. So those are the kind of people that they are. Now, in Noonan syndrome, it is also a genetic disorder that may present with mildly unusual facial features, short height, congenital heart disease, bleeding problems, and skeletal malformations. All right. So that is for Noonan syndrome. Usually they are short, but over here they say the person is tall or the person is tall. Yeah. Then we also have the Ehlers-Danlos syndrome, which normally involves a stretchy skin that bruises easily. They bruise easily and they have delayed development and so on and so forth. Good. So over here, definitely Marfan syndrome will be our answer. So the answer is D. A 42-year-old man who is a minor was freed after 12 hours spent under the rubble. Oh, okay. Objectively, his both lower legs and feet are pale. Okay, they are pale. Okay. Just the lower legs and feet. There's no palpation on the peripheral vessels. No sensitivity, no passive movement in the joint. What comes to your mind? Maybe the place is not more working, right? Maybe. But what happened? They said he was hospitalized with tourniquet applied to both limbs. Oh, what agent first aid must be in this case to prevent myoglobinuria and acute kidney failure? So this myoglobinuria is substances from the muscle breakdown, and it can really destroy the kidney. So you don't want to have your patient to go through that process. And that's the reason why anytime patient comes to us and then it's from an accident, we always have to do our renal function test to check the state of the kidneys to make sure that the kidney is not in any danger. It's not in any danger. Good. So having said that, let's move to the question. Let's analyze it again. So this person is a minor and maybe there was a rebel. So there was maybe something hit his legs or something like that for 12 hours. Then after 12 hours, the person was now freed. Just like what happened in Istanbul. May their soul rest in perfect peace. But something happened in Istanbul few months ago. And unfortunately, one of you know one of the Ghanaians was entrapped over there. Unfortunately, the person didn't make it. So unfortunate, but he didn't make it. All right. One of the things I presume can kill the patient is this condition that we're about to talk about. Kidney failure can kill the patient, apart from the fact that patient will be hit by a lot of stones and things like that. Apart from that, this can also kill the patient. All right. So this is not far-fetched. It's something we can relate to. All right. So now patient has come 12 hours after spending under that area. Now both limbs are pale, meaning it is white. No blood is moving to that area. And they've gone on to say there's no pulsation. No pulsation, no sensitivity. So what I can think about it, maybe those areas are already dead. Or the affected limb is dead. And the affected limb is dead, you have to cut it off. And that's called what? Amputation. As simple as that. That is called what? Amputation. So, if that is the case, now, it's two ways to look at it. All right. If that is the case, then we can say that you do not need to remove the tourniquet. All right. You don't need to remove the tourniquet. Amputate above the tourniquet. That would be fantastic. Right? That would be fantastic. Now, assuming the tourniquet was also used to prevent bleeding, okay, maybe below where the tourniquet was applied, there was some sort of bleeding, but I'm sure they would have presented it in the question for us. Maybe they were bleeding profusely from the lower limbs and things like that. So you apply tourniquet. But there's nothing like that. But if something like that was there, then you just have to what? To remove the tourniquet and then provide the oxygenation to the area and secure hemostasis, as simple as ABCD. Secure hemostasis, as simple as that. All right. So over here, like I said, based on my first explanation, definitely I'm going with what? With D as an answer. Do not remove the tourniquet, amputate the limbs above the tourniquet, with the idea that the lower limb is dead. Yes. After the 12 hours, that lower limb is dead, or those areas are dead. So you just have to amputate it. So that's why I will go for D. Unless Krok is trying to picture a new, another history, but it's not written here, so I can't defend it. What I can defend is what I'm telling you now. So over here, I'm going in for D. All right. Now, 26-year-old woman who has been suffering from rheumatoid arthritis for 5 months, rheumatoid arthritis for 5 good months, has edemas on her elbow, radiocarpal knee, and then the ankle joint, and rheumatoid nodules on the area of her elbow joint. Complete blood count, ESR is 57. C-reactive protein is 3 pluses. X-ray of the joint reveals marked osteoporosis. So now you have what? Rheumatoid arthritis with osteoporosis. How do you manage this patient? How will you manage this patient? So normally, treatment of osteoporosis in rheumatoid arthritis, guys, write this down, is simply by methotrexate. Methotrexate. And they also have other conventional, we call it conventional disease modifying anti-rheumatic drug. Conventional disease modifying anti-rheumatic drug. Example is the sulfasalazine. We have levonomide. We have hydroxychloroquine, and so on and so forth. But again, the group of drug is called what? Where's my mouse? So we have what? C, D, M, A, R, D, S. Conventional disease modifying anti-rheumatic drugs. All right. So over here, our answer is definitely what? Methotrexate. That's the first choice of drug we will use. Methotrexate. So your answer here is what? Is A. Answer here is A. Please, if you want more of this, try and be on this channel. Try and subscribe to this website. All right. And let's get the rest out as soon as we could. Okay. Stay blessed.